Associate Professor in the Research School of Population Health in the National Centre for Epidemiology and Population Health. I'm teaching this section on health protection for the Fundamentals of Health Protection and Health Promotion, MEDI8115. This is a recorded lecture, and next Monday we'll get together to review some of the concepts I'm teaching you today and also to go over some case studies that reflect what we've been discussing. So today I'm going to talk to you about protecting health. It's very much around the functions of health protection that governments do and also associated industries. So I'm going to be talking a little bit about how it transitions over time. And here you can see a picture of a swimming pool in the 1900s and how things have changed. Today I'm going to be talking to you a little bit about what is health protection, giving a definition and show you how it fits in with the other functions of public health. Talking about public health working arrangements, and I'm going to be talking about the transition of health protection into more mainstream society and other government departments and agencies. And you'll see as we go through that things have changed over the last 100 years. I'll be talking to you about emerging infectious diseases on Monday, and we'll go through a couple of examples and also some non-communicable ones as well. And then finally, I'll just give a summary. But first, let's talk about the 10 essential public health services. And this really covers the entire public health remit. So everything that government does, that non-government organisations do, that industry do that's public health minded, and that academic institutions do. So the first of these is to monitor health status, to identify and solve community health problems. So that might be public health surveillance or something similar to that. Bowel screening is an example. Secondly, public health diagnoses and investigates health problems and health hazards in the community, with the emphasis being on the population. So this is an investigative component where there's a need to actually find out the nature of a problem, whether the population is at risk. And this is very much fits within the remit of health protection. Thirdly is to inform, educate and empower about health issues. And you can see this goes back to health promotion very much. But there's a real crossover in the health communication between health protection and health promotion, and we'll discuss that as we go through and also in the face-to-face session on Monday. Fourthly, public health mobilises community partnerships to identify and solve health problems. I think this reflects that good public health happens in teams. So it's not about just one agency working to solve a health problem. It requires cooperation from the community, from activists, from community actors, and also from a range of other stakeholders who can help to improve the health of a population. Fifthly, to develop policies and plans that support individual and community health efforts. Sixth, to enforce laws and regulations that protect health and ensure safety. So very much what we'll be talking about today in the form of health protection. 7, to link people to needed personal health services and assure provision of healthcare when unavailable. So we will often find that public health in resource poor settings may have to man clinics and provide services where there's no extant health facilities provided. 8, to assure competent public and personal healthcare workforce, which is why you're doing the MPH or some other study of a similar nature here at the ANU. 9, to evaluate effectiveness, accessibility and quality of personal and population health services. So this is really getting back to the fact that we need to be constantly evaluating our efforts to make sure that we're doing the best we can. You will notice that many public health initiatives are not necessarily based on the best evidence. They're based on what we know and hope will work often, rather than information that's really been proven and tested in a population health context. So we have an obligation to improve how we deliver public health services and improve them as we go along. And then finally, research for new insights and innovative solutions to health problems. So they're the 10 essential public health services. And as we're going to just talk about the definition of health protection, you'll see where health protection fits into several of those, but particularly around promoting health, enforcing laws and regulations, identifying and diagnosing and investigating communities. So when we think about promoting health, there are really three parts. Firstly, health education. So this is very much communicating to the population about factors that might improve their health, and just general health education to prevent disease. We then have health protection, and finally prevention. So these three things fit together very neatly and in partnership. Hence why this course contains both health promotion and health protection together as partners. And you'll see they provide two different parts of public health functions. So what is health protection anyway? Health protection is the protection of public health from environmental contamination. The emphasis here is on the population level. It's not at the individual level per se, but we're really generally thinking about protecting public from environmental contamination from a microbial cause, chemicals, radiological. There's an acute response function often where there is evidence of contamination that needs to be investigated and responded to. And there's also different operational models. It's also true some of the other kinds of functions of public health would fit into health protection as well, like regulation of drugs and poisons, and is often considered health protection. Similarly with things like preventing road traffic accidents, you'll find when we think about the framework for health protection that those kind of injury prevention measures fit in very well. So preventing injuries from fireworks is a good example. So I'm happy to discuss this when we meet on Monday. If we consider the policy development cycle that is used for government and other agencies developing policy, the first thing that happens is obviously identification of an issue, which then moves on to developing a policy instrument, which is then hopefully there's some consultation with stakeholders and those who are affected and the community of stakeholders, which is then coordinated, the response is coordinated, a decision made about the approach taken to develop the policy and implement it, and then ultimately, once it's implemented, it would go back to evaluation to evaluate whether the policy has actually worked, and that would feed back into identification of future issues. And similarly with health protection, we can think of it on a similar basis. If we wanted to, we could identify the issue as the disease or contamination event. So it might be lead, which is a problem for contamination and has significant child health impacts due to reduced IQ in people who've been exposed to significant levels of lead. We then move on to control strategy development. We might identify what the parts are to limit people's exposure to lead, and if it was a town where there's a lead smelter, we would be looking at minimising contamination of the soil or contact with the soil, making sure that people, young children don't eat soil, so we'd have identify different controls, which would then feed into consultation with experts, industry and the public. So in that instance, we'd be talking to people who are environmental health experts, parents, school teachers, kindergarten teachers, to try and identify whether the control measures would work. We would then be coordinating the response to try and implement that particular piece of work. And then we'd decide on the intervention and make sure that that was going to have some impact, and then we'd evaluate it through evaluation of control and surveillance measures. So something that's very strongly at the heart of health protection is risk analysis. And risk analysis is an overarching framework where there are three components: risk assessment, which flows into risk management and then flows into risk communication. You've already had some discussions about risk communication, where the risk communication is a critical part of alerting the community, but also allaying their fears and protecting them from further harm. So these particular pieces are critically important to science and policy, and they're key to public health action. They each have specific frameworks for developing risk assessment, management and communication, and we're not going to cover them in detail here, but it's important to know that they exist. Risk assessment incorporates 4 different parts, which is hazard assessment, so assessing what the hazard is, looking at whether there's a dose response so that we can identify what is a critical level of exposure, which is then assessed in a specific exposure assessment, what proportion of the population is exposed. And then finally, what is the characterisation of the risk? How many people are going to end up sick at given levels of exposure, and so that we can minimise it. There are a range of different key interventions that are employed in public health for different types of hazards. A good example is vaccination for infections. There are many infections which have been, there are effective vaccines which have resulted in huge reductions in morbidity and mortality, and that's all part of the health protection framework. For radiation, there is personal monitoring of doses. So a good example is the dosimetry measurement for people exposed to radiation, so radiation therapists or radiologists and radiographers that have personal exposure measured and monitored so that they don't get too much exposure to radiation. Drugs and poisons, obviously legislation and labelling being critical interventions, along with monitoring of prescribing practices for drugs of dependence, which are interventions to ensure the safety of our drug supply in the populations. For food safety, there's pasteurisation, which is an example of an excellent means of reducing the risk from foodborne microorganisms for things like pasteurised milk and pasteurised milk cheeses. And we'll be talking more about food safety in one of the other sessions following this particular one. And then water quality, where water treatment is incredibly effective at reducing the risk from waterborne microorganisms. So a key part of the health protection framework is public health legislation, and the public health legislation provides powers of enforcement for health agencies. You'll find in Australia that public health legislation is largely enacted at the state and territory level, because under the Constitution, powers of public health enforcement are devolved to states and territories. So the Commonwealth has a coordinating function. The Commonwealth does possess national legislation on some functions of health protection, so setting standards for food safety or monitoring the safety of drugs and poison through the Therapeutic Goods Administration. But in the main, the enforcement of public health occurs at jurisdictions. It's important to recognise that public health legislation can encourage people to cooperate, or it may coerce them to actually to carry out certain things. The powers in the legislation often allow for investigation, collection of information, seizure of products, closure of premises. They specify what kind of fines are actually payable if people breach these. Mind you, the fines can actually be very small in comparison to some of the consequences. So we'll be looking at some legislation that protects health, and you'll see that the fines are very small in comparison to what the consequences can be. And there are also complementary pieces of legislation not managed by public health but have a public health function. And a good example is Environmental Protection Acts, which incorporate aspects of legislation that protect public health, even though they're not managed by a health department. So as I said, in Australia, powers are vested in states and territories. So the legislation in states and territories managed by public health allow them to do things like public health surveillance, to identify and investigate risks, potential risks to health and emergencies. And it may be regional in nature. So in somewhere like New South Wales, there will be area health services that cover large geographic regions and large populations. And they have the state health department has a coordinating function of those different area health services. In contrast, you can also have situations like, say, Victoria, where there is most of the public health is centralised in the health department, and they cover activities for the whole state. In many instances, powers are devolved to local government, so inspection, investigation, prosecution. And if you think about inspecting food businesses, for instance, that is not the job of central government in most state and territories in Australia. It's actually the job of councils or a food authority. Similarly, to investigate local public health problems, they will be in bylaws in councils, and also for prosecutions as well. There are national level acts and agreements, such as the Quarantine Act, which has just recently been replaced by the Biosecurity Act nationally. The Health Security Act 2008, which allows for the Commonwealth to forward information about internationally important public health risks to the World Health Organization and other international health bodies. And there's also a health security agreement which outlines a national notifiable disease list. So that allows for surveillance to occur at the national level, where the Commonwealth is able to aggregate data from states and territories, which are also collected under their local, state and territory public health acts. And it allows for a national level collection of data and identification of problems. So if we think about, given that Australia is a federated system and we have these powers which are devolved to states and territories, we know that many hazards do not respect state and territory borders. A good example would be bats, which they don't care whether they fly from Queensland to New South Wales and cause a problem in both places. So there's a need for great cooperation in Australia. In Australia, for communicable diseases, for instance, we have the Communicable Disease Network Australia, which answers to the Australian Health Principal Protection Committee. The Australian Health Protection Principal Committee is one of a principal RMAC committee, and it has a range of different subcommittees, including the Communicable Disease Network Australia, the Public Health Laboratory Network Australia, NHealth, which deals with environmental hazards, and All Hazards, which is dealing with public health emergencies such as mass casualty events or bushfires. So each of these committees has a role in coordinating activities across state and territory borders, and they report up to AHPPC, which is a RMAC committee, which is chaired by the Chief Medical Officer of Australia. It's designed to provide coordination of health protection efforts. If we just look at an example of public health legislation, this is the South Australian Health website, and you can see here they've got a range of different activities which protect public health, and I'd encourage you to go and have a look at their website. It's an excellent example of different pieces of a jigsaw puzzle working to protect the health of South Australians. It's developed over well over 100 years, and it's quite sophisticated. So if we look at they've got a Public Health Act which establishes who is authorised or may be delegated, so it names specific positions. So it might be the Chief Health Officer for the state, and that Chief Health Officer might be able to delegate some of the functions to people within the organisation. The Public Health Act establishes a framework for reporting, enforcing and penalising people and organisations that breach the Act. And more importantly, it provides a head of power to make regulations on a range of different things. So we'll see later there's regulations to say what diseases are notifiable, and they could be everything from an infection like Legionella infection right through to something that's not infectious like elevated blood lead levels, because there might be a need to know about a population which is exposed at higher than normal levels and intervene. Right through to environmental health, Legionella control, which we'll be talking about in the case studies on Monday, swimming pools and spa pools, cervical cancer screening, waste control, and many more. So there is regulations which basically flow on from this Public Health Act. There are also non-regulatory measures which are important as well, so standards which might be international or national, and they may have very strong health protection measures within them. So standards for maintenance of cooling towers, which can, as we'll see, can actually disseminate Legionella bacteria. They actually have a public health function, but their key audience is building owners and managers, water treatment companies, and they don't even mention that they're part of the public health family, for instance. So they're very important. Codes of practice, which might have been established by an industry group or public health agencies. Risk communication, and as you will have heard in the previous session on risk communication, it can be a very powerful tool for directing the activities of a community. And in health protection, it's particularly important in outbreak or incident management situations where you want the public to do something like avoid certain areas or drinking the water, or you might want them to do certain things like actually go and seek health consultations if they're concerned about certain symptoms, and so you can actually identify them. And there's also other things like cultural norms as well, which can have a health protection function. So a couple of examples: water quality. Water should be free of disease-causing agents such as bacteria, viruses, protozoa, and chemicals. And the main way that this occurs is treatment and disinfection. So water supplies are treated at source. So by the time it gets through to the consumer, it should be free of disease-causing agents, but also non-disease causing agents but have an aesthetic quality as well, such as turbid water or saline water. And the way we assure its safety is usually through disinfection. There's a need to conduct monitoring and surveillance, and that is often mandated in legislation. So regulations will state how monitoring and surveillance of water supplies is to happen, and it will give an assurance of protection for the population. Similarly, sewage treatment is very similar, although there is generally in high income countries, there's a clear separation of sewage and drinking water supplies or contact with humans, and the main reason being is that it has a potential to infect people with agents that we really don't see so much anymore. And it's the way that is managed. There are regulations, they're not necessarily in health any longer, but there certainly is guidance on reuse. So where water authorities are reusing sewage as a source of water and fertiliser for market gardens, there's guidance on how long it should be stored and treatment guidance so that it doesn't cause infection. And it's true to say that many of these things are actually in an engineering setting. So engineering used to be part of health departments many years ago in the 1930s through to the 1990s. Engineers were a key part of the health department, and they looked after regulations and dealt with water authorities on water and wastewater treatment to prevent infections in humans, and also to deal with issues of odours and smells as well, so that because they're considered public health concerns. And if we think about all of the issues relating to water supply, here's a diagram just showing all the potential sources of contamination. Everything from homes in the catchment area or a city that might be contaminating a water supply, croplands with chemicals, suburban developments, animal feedlots with concentrated animal feces, sewage treatment plant, factories. And these are all the types of inputs that water supplies have and need to be dealt with to make water safe for humans to drink. And it's quite common in water catchment zones all throughout Australia to have these kind of pollution inputs. The engineering solutions have been designed over the last 100 years to deal with many of these. And here's just a photo of a toilet in Pompeii in the Federated States of Micronesia, and just showing that where you have these kinds of situations where there is no effective treatment of sewage, you have the potential for large outbreaks of diarrhoea. And this is really a situation where we would expect to see diarrhoea at higher levels than we would where there's treatment of waste that's taken away in pipes, treated in a sewage treatment plant, managed in terms of how it comes, the waste is used. And that is exactly what occurs. So we see different types of diseases in low-income settings where there's not these health protection measures, and higher levels of disease as well. So as I mentioned, water supplies are treated, and this is just a schematic diagram just showing how water will be abstracted from a water body, hopefully in a situation where there's not, humans do not have access to it, and there's limited access of animals to minimise contamination. Taken in pipes, and there's coagulation or flocculation is applied, which is where they add chemicals to remove some of the sediment and some of the larger particles before it goes through a sedimentation tank to take away all of those particles which are coagulated into larger clumps. And then it goes through a filtration plant which removes some of the finer particulate matter and some pathogens like cryptosporidium, which are microscopic. And then finally the water is disinfected either using chlorine or UV ultraviolet light or ozone to ensure some protection for the water and to kill microorganisms that can pass through some of those preceding steps. It's then often put up into storages, with elevated storages, which are then gravity fed down into the reticulation of a town. So that's very well worked out through engineering principles, but has its origins in public health. And you can see some of those interventions are critically important from a public health perspective to remove microorganisms, to stop outbreaks. We apply engineering principles in various different steps throughout that process. Critically important, obviously, source protection. But then we also need to think about supply protection as well. In some instances, we find that there is coagulation, sedimentation, but no filtration. And the question is, how will that affect the supply? We'll be discussing a situation that occurred recently in New Zealand, and I think you'll probably already talked about it, Havelock North, and we'll be looking at water quality and how you can protect sources and what were the implications of that particular outbreak in New Zealand in Hawke's Bay area. What was the situation in terms of protections for the residents there and what went wrong? So we're going to be looking at that in a bit more detail. For recreational water, such as swimming pools or spa pools, the main interventions are disinfection, usually using chlorine or bromine or some other chemical, and many will have experienced the very strong and pungent smell of chlorine when you've been in an indoor pool. Also, filtration is critically important of water supplies in these settings because the water is recirculating. You want to remove any particulate matter before it gets recirculated back to the pool. Most states and territories have guidelines or standards that supplement the regulations. So the Public Health Act says what the regulation is going to be about. The regulations actually specify in more detail, and then the guidelines or standards outline exactly how water operators in pools are going to manage microbial, chemical risks and also bather loads, because obviously if you have more people in a pool than the pool can reasonably sustain, the disinfection is going to be ineffective and you're potentially putting people at risk. And there's also compliance monitoring usually specified. So in a pool setting, you would expect that the pool operator would be conducting regular checks of disinfection residuals every 4 hours. So they might be doing just a simple test and recording those down. So swimming pool treatment, here's a schematic of swimming pool treatment. It's far more compact, obviously. So we have the pool, and then you can see that it's going out to a filtration system, and there's large pumps because they're recirculating the volume of the pool through very quickly. And because they're often at a warmer temperature and there's more bathers, we might need to adjust the pH of the system. Particularly, the main reason we want to adjust the pH is to ensure that the chlorine disinfection is effective, because chlorine actually doesn't work as well if it's if the water is not the right acidity. So you might need to adjust for that. There's obviously other disinfection systems, and in this one here you can see in steps 13 and 14 there's the addition of ozone, which is a form of oxygen which is much more reactive and kills microorganisms. The other function that disinfection often has in swimming pools and spa pools is that it oxidizes organic matter. So it's really destroying some of the organic matter that's being shed from bathers' skins, oils, that kind of stuff. Other things that we won't mention. obviously, and then it's recirculated back into the pool. It's far more intensive than a drinking water supply because it's a recirculating system, often at warmer temperatures where microbial growth is much greater. So you definitely need a disinfection residual, which is something that the swimming pool operator can actually measure and monitor. So radiation safety, many health departments have a radiation safety section which has a role in accident emergency response, but also, more importantly, protecting public and workers from radiation through exposure through X-rays and CT machines. So they're regulating ionising radiation in the medical, research and industrial settings. And they also have a role in regulating non-ionising sources of radiation, such as tanning salons. And they provide expert advice on exposure. But all of that is supported by legislation, and it enables safe use of radioactive sources. In terms of food safety, regulation of the food system is quite complex and well established. Food is a big business, and food is a globally distributed commodity. It doesn't respect borders. It travels internationally more than people. And even in Australia, it doesn't respect borders. So while we have health protection oriented legislation in each state and territory, they are generally harmonised because of the movement of food. So the regulation of the food system is quite complicated. There is food premises inspection, so just looking at the restaurant level inspection, or the food premises like a food factory, which is done on a state and territory level, which may be devolved to councils or some other body. There's a risk assessment role, which occurs where there is a potential risk, and health authorities want to understand what the nature of that risk is. Food testing, there is certainly at the state and territory level testing occurs where of foods, but that is really a very scattergun approach to identify contamination through food testing. So it has to be on a risk assessment basis and identifying foods which convey the greatest risk. And then food labelling, which is dealing more on the side of allergies and nutrition, but still has an important health protection role. And then finally, recall. So where there has been contamination identified, recalls of products are undertaken, which is specified in legislation. And speaking of foods which might present a risk, that you can see here alfalfa sprouts, and they've been the source of several outbreaks in Australia, and probably more importantly many outbreaks overseas, where they're easily contaminated by enteric organisms internally, so organisms like Salmonella or E. coli that can cause infection and quite serious outbreaks. Most public health legislation in states and territories also specifies how infectious diseases will be kept under surveillance, and also how outbreaks will be controlled. So all state and territory health departments in the country have specific programs to deal with purchase and distribution of vaccines, managing sexually transmissible infections and contacting people through contact tracing, bloodborne infections, parasitic diseases, tuberculosis, and each of these different types of diseases that I've split up here by spread really get different types of responses as well. So the public health response to a case of malaria is very different to a public health response to a case of tuberculosis, where there is a far greater risk of ongoing transmission from tuberculosis if it's in Australia. So there's a distinctly different model of operation. But as I mentioned before, the surveillance of infectious diseases occurs at the state and territory level where the powers are vested, and then the data are centrally aggregated at the Commonwealth, and there are systems of committees in Australia that actually manage the assessment of risk across the country, and they're particularly looking for changing surveillance data which indicate an increase or a decrease in disease, and also clustering of disease that might indicate an outbreak, either by type, by place, by person, and so the system is quite complex and has been built up over many years, but works well. Similarly, for environmental health, there's a range of different issues that environmental health has to contend with, and these are usually documented in legislation, including contaminated sites for chemicals, miscellaneous chemicals, air quality, noise, waste disposal, cemeteries. And some of these there might actually be additional ones which we haven't thought of. For drugs and poisons, there's the need to regulate the drug supply and monitoring drugs of dependence prescribing, because you can find that there are doctors that are over-prescribing opioid drugs to people who are doctor shopping, scheduling drugs and other similar things. There are many really fantastic health protection successes, and one example is vaccination that has achieved the eradication of smallpox, and there's several other diseases that are nearing eradication, and obviously polio is one particular campaign. And this particular picture down on the bottom right is a man in Ethiopia reading from a wood tablet, and this is during the final campaign to eradicate smallpox from the world. Water supply treatment has made huge impacts on public health and the well-being of communities, and we know that it's decreased rates of diarrhea dramatically, and it has vast effects on the health of populations. The irony is, when you are doing a good job with these things, there's an absence of disease or a problem, so it doesn't always mean funding is maintained. Swimming pool disinfection has eradicated many terrible diseases, and no doubt polio and other enteroviruses were transmitted through swimming pools prior to disinfection. For food safety, milk pasteurisation has to be one of the great successes for food safety, and has eliminated many dangerous infections such as salmonella infections and toxigenic E. coli, including typhoid. There were many large outbreaks of typhoid from ill workers in dairies providing people with a source of typhoid. Also, tapeworm prevention through eradication of tapeworms in many of the animal species, through animal health interventions, and also meat inspections as well. So some really fantastic successes in health protection, and there's probably many more, and maybe that's something we'll be interested to hear whether you can think of any and bring them along as we discuss it next Monday. It's worth also mentioning bioterrorism in the context of health protection, and many people will not realise, but it's the example, it's the origin of the Centers for Disease Control and Prevention in the US. It was one of the key things that made them a large and robust organisation. They originally were designed to control the spread of malaria in the United States, but their mandate was expanded to include bioterrorism agents due to the Cold War. A couple of examples. Firstly, salad bars in Oregon. There was a particular religious group, the Orange people, who wanted to see if they could influence local government elections by creating an outbreak, and so they used salmonella. It was actually a type strain, so one you could buy for quality assurance purposes in laboratories. And they went and sprinkled it on different salad bars in restaurants in the town and caused a large outbreak. Well, CDC went to investigate, but they knew it was salad bars, but they could never identify what food because it wasn't consistent, which made sense because they had sprinkled salmonella on a range of different foods. They were also confused by the fact that it was a type strain, and they weren't necessarily thinking bioterror, and it was only when the deputy head of the Orange people confessed to this poisoning, and she was a microbiologist, and it was only then, so it just points out how difficult it can be to recognise where it's a stealth vehicle. Another example is the anthrax white powder events that occurred in the US following the 9/11 outbreaks in 2000, the 9/11 airplane crashes into the Twin Towers in New York in 2000. And it was this was a terrible outbreak where people were distributing type strains of anthrax through the mail supply. And so people were getting respiratory anthrax when they were opening these letters. Not a lot of infections, but a lot of really difficult investigations, and also a lot of copycat investigations with white powders, which wasted a lot of public health resources. But given the seriousness of anthrax and the high case fatality rate, it was important that there was a robust investigation and response mechanism. Do we really think it's an issue? It probably is for protection of public health, and it did provide resources for public health protection as well. Many of the following on the white powder incidents with the anthrax in the US, there was a lot of money flowed into public health to improve surveillance and improve our understanding of the potential of bioterror to cause widespread disruption of the health system. Some of the things that are against it being an issue is that it can really slow down public health functions, and it diverts resources from real public health problems. Now, as we've been discussing, we've obviously been talking about some of these regulatory measures for health protection. They originally started out as basic sanitation and hygiene back in the late 1800s and early 1900s, when people began to recognise the connection between sanitation and hygiene and good health. So health departments actually developed legislative instruments to be able to protect the health of the populations, and some of these included work that is now no longer contained in those health departments. Over time, there was a separation of protective functions, and we end up with a complex system with specialised functions. So you'll see that in most governments in Australia, that there's this separation of different types of departments managing all of these particular functions. So originally it was only the health department, and the health department had people dealing with meat inspection and wastewater, engineering, and then over time you had a health and a public works department, so they'd be separated, and so the people dealing with the water supply and the wastewater would go into a new department that managed distribution of water and removal of sewage. And then over time, into the 1980s and onwards, we had a quite complex system of eventuate, which included a health department that concentrated on the core public health things we know about, public works departments that manage water supplies and wastewater, environmental protection departments who managed the pollution of waterways and contaminated sites and those types of things, and also water authorities as well that were also involved in water treatment. So it's become a lot more complicated, and over the years things have diversified and health departments have been left carrying the main functions of public health. But it's important to recognise that many of these functions have actually been devolved to other agencies. I'm going to spend a bit of time talking about emerging infections because they're an area of health protection that are quite difficult. And it is true to say that much of health protection is often dealing with the worried well. So people who are not yet sick and have a low potential for becoming sick but are worried about it. And emerging infectious diseases falls into this area, as do things like environmental health issues where people might be exposed to low levels of chemicals but they're worried about what the impacts are, and it's hard to reassure them. So what are emerging infectious diseases? An emerging infectious disease is one that has newly appeared in the population or existed but is rapidly increasing in incidence or geographic range. And here's a picture from a landmark report in Nature in 2004, just showing examples of emerging and reinfectious diseases throughout the world. And there's a range of different ones. And you can see in Australia there's a dot there for Hendra virus, and we have Nipah virus in Malaysia, H5N1 in Hong Kong. So there's a range there. Please feel free to have a look at that, and we can talk a bit more about that on Monday. But in today's world of rapid travel and transport, reintroduction of infectious disease occurs not only locally. Humans, insects, livestock and food products carry these agents from country to country and continent to continent. Infectious agents carried by humans are often asymptomatic or in the incubation period, while those carried by insects, livestock and food often remain silent, which is why they're so challenging and potentially dangerous, which is why the world became so worried about Ebola in 2014. So some of the factors in emergence is economic development in those countries. There's been rapid economic development without infrastructure. So where you've got cities built up and there's not infrastructure such as water supply and waste disposal. Land use, so deforestation or development of land without proper preparedness or dealing with wildlife. Human movement and behaviour is critically important. International travel and trade has increased massively, and the globalisation of the food supply and trade and transport has meant that infectious agents can travel very rapidly. And also animal density, where people are farming with very big herds that are very concentrated, you've got potential for greater spread throughout the animal herds, which didn't happen many years ago. And then finally, changes in pathogens. So we can see emergence of antibiotic resistance that hasn't been previously seen, and that might travel because of its fitness. So it may end up being able to sustain infections and be untreatable and then travel and emerge in a new area. So in Australia, if we think about infectious diseases, we have known diseases under surveillance. There's over 65 diseases under surveillance in Australia. For unknown diseases, we have legislation which gives us power to investigate. Nearly every jurisdiction in Australia has powers to investigate infectious diseases of unknown origin. And that might include emerging health risks as well. So if there's a disease of unknown etiology or source, health departments can investigate. For known diseases, we have control programs such as vaccines, health promotion, other interventions. For unknown diseases, it's really about broad monitoring for their occurrence, and that's usually through syndromic surveillance, where we're looking for a constellation of symptoms, or so it might be keeping a syndrome like encephalitis under surveillance to see if there's any emerging infections, and also alert clinicians, which are a key source of identification of new syndromes. For known diseases, we know they have high burden. So a disease like pertussis causes, thousands of infections every year and occasional deaths in infants that are unvaccinated. Compared to unknown diseases where it's more community concern, so if we're talking about something like Hendra, where it's not easy to have under surveillance, or other diseases like it, it's really the community is concerned. So I'm going to tell you a bit of a story about infectious diseases, and it highlights the importance of health protection. It's a story about sesame seeds. In 2001 in Victoria, there were 14 cases of an unusual strain of Salmonella typhimurium, definitive type 104. So we don't see this strain in Australia at all, really. The key thing about this strain is it's antibiotic resistant to a range of different commonly used antibiotics. All the people who were infected were of Middle Eastern ethnicity. The health department had investigated and thought that cheeses and yogurt were common foods consumed by all the cases, which is not surprising when you think about people from the Middle East. Anyway, they did a case control study and they found that cheese and feta were equivocal, so there was no strong association between eating these foods and becoming ill. Shortly after they had finished this case control study, there was a report in Eurosurveillance, which is an international journal of infectious disease threats, that reported on an outbreak of Salmonella DT104 in Sweden, where they identified that it was caused by helva, which is a sesame seed product, a sweet, which has got high sugar and high fat, that originated from Turkey. So Victoria ran their case control study asking about helva, and sure enough, cases had all eaten this consistent brand of helva. They tested the helva in Australia and it was also positive for Salmonella typhimurium DT104. The implications of this is that there was an international food recall. So once the source was identified, the health department communicated it to the national focal point, which then distributed that information through the international health regulations and other foodborne disease investigation networks. And there was a recall on 3 or 4 continents for this particular helva. It also resulted in about $1.3 million worth of savings because they were able to destroy a good proportion of the shipment of this particular product. It was a lot of it hadn't actually been distributed, so they were able to recall it and destroy it. The other thing is it changed the import testing of all sesame seed products. We hadn't really recognised that sesame seeds were a big risk for foodborne disease before from Salmonella. So they went from a low risk product to a high risk, which meant that every consignment of sesame seed products now had to be tested for Salmonella. And if we look at a report from the Department of Agriculture that was taken in 2010, but if you go and have a look at last week's, there'll be sesame seed products positive for Salmonella, and this is the list of all the foods that are positive in that particular month, April 2010, and you can see here I've zoomed in on those particular rows that halva with almonds and hulled sesame seeds from Egypt and India, both positive for Salmonella. And every month the import testing regime detects Salmonella because of that outbreak, and that just highlights the importance of good investigation there, change to health policy and regulation, and ultimately protection of the community from Salmonella, because these Salmonellas might only infect a small number of people that end up being detected by surveillance, but there may be many infections in the community. We know that about 1 in every 6 to 7 people who are infected with Salmonella end up going to the doctor, getting tested and being reported to the health department. So a really good result from some outbreak investigations. Another example, this is the Whyalla pipeline, where water is transported overland in these pipelines from Morgan out to Whyalla in South Australia. And as you can imagine, going overland in these pipes, water gets very hot, particularly in South Australia, where it can get up to over 40 to 45 degrees in midsummer. So the water in these pipes would get up to 40 degrees. This turned out to be very good growing conditions for an amoeba called Naegleria fowleri. And what happened was a number of cases ended up getting infections when they got water up their nose, it allowed amoebae to go through the cribriform plate and result in primary amoebic meningoencephalitis, which is uniformly fatal and has disastrous consequences. So there were several cases in this particular area of South Australia, and there was a need to do something. So what was the solution? The first was to improve water treatment so that these amoebae couldn't actually grow in the water supply. So they changed the disinfection regime to use chloramine, which is actually much longer lasting, much more sustained, so that the chlorine would last the distance. As you can imagine, with chlorine in very hot temperatures, the chlorine dissipates much more quickly, but this is a more stable form of chlorine, so that lasted longer. They also put supplementary dosing stations along the pipeline, and they maintained a 0.5 milligrams per litre chlorine residual, whereas previously the chlorine would dissipate, and by the time it got to the end there'd be no chlorine left, and the amoebae would be able to survive, and it would result in infections. And they also advise people not to splash water up nose. You'll also find that this is the case in New Zealand in the hot springs, where there's advice there, do not splash water up your nose. It's for this same organism, Naegleria fowleri, and also some other species of amoebae, acanthamoeba. So these are emerging infections that can occur if the circumstances are right. And this is a non-regulatory approach to improving the water supply to protect the health of the people. A couple of things about health protection. Are the protections evidence-based? It's something I want you to think about between now and the session that we have next week. And my reason for asking this question is that you find many of the things that we enforce in regulations or standards are more about our concerns about hygiene rather than our concerns about protecting health, and is the evidence really there to support it? So I want you to think about that. Some future issues for health protection, obviously to improve the evidence base. We need to gather more information that the control programs we have in place actually work. There's continuing tension over the health budget, and so things like neglected tropical diseases miss out, yet they can cause a huge burden in low and middle income countries. We're also seeing non-communicable diseases being a major concern, and there's tension over how much money is allocated to that. And the actual regulatory approaches for some of them as well are quite difficult, and we just need to think about how we protect the health of people from those diseases. We need to develop our understanding about animal-human interaction and environmental sources of disease. And we need to develop new response capabilities in regards to epidemiology and laboratory. There's continually disruptive influences in technology, and we need to be taking advantage of that. So things like whole genome sequencing or new ways of collecting and analysing epidemiological data. So we need to be incorporating that and making sure we're changing our approaches to best protect health. So in summary, health protection is an important public health function characterised by the need to minimise exposure to acute or emergent hazards of infectious, chemical, radiological or biological nature. In particular, emerging infectious diseases are challenging due to the unknown nature of infections and their mode of spread. So I showed you this before. What's different? Health protection works. I'm going to look forward to seeing you on Monday, and we'll be going through some case studies and reviewing some of the concepts we've talked about today. Thanks very much.